So now let's turn to another drug approval in the last couple of years, and that's glasdegib. Jorge, you led that trial.
Yeah, it's an interesting trial and it's an interesting drug. As you know, glasdegib is a smoothing inhibitor, and that goes through the hedgehog pathway that's very important in embryogenesis, but it's shut down essentially at birth. But it is very important in the maintenance of the cancer stem cells in general, and certainly of acute leukemia. Stem cells. These drugs have been mostly investigated and approved in basal cell carcinoma of the skin. That's where some of the others, not glasdegib, but some of the others have been approved, and that's their benefit. Well, this drug, we did some early preclinical work in leukemia, Katrina Jamieson and UCSD, and showed some potential benefits. So that led to the investigation in AML. So to make the story short, after investigating single agent and some phase 1 data in combinations, we took these to this randomized phase 2 study of low-dose RLC alone or in combination with glasdegib. This was meant for patients who were over the age of 55, but who had comorbidities that made them not good candidates for intensive chemotherapy. And they were defined in the study as being at least one of being 75 or older, having a performance status of 2 or greater, having a creatinine above 1.3, or having poor cardiac function, decreased ejection fraction, or some other cardiac problems. You know, the median age on this study was over 75 in both groups. 60% of them had cardiac issues. 50% had a performance status of 2 or more. So it was really those patients. The primary endpoint of the study, so the glasdegib is given orally, so that was continuously administered. The cytarabine was these Alan Burnett's defined twice daily for 10 days. And then the primary endpoint was overall survival, and the study was very positive. It showed essentially a doubling of the survival from 4 months to 8 months, the median survival. And we're actually at ASCO here. We are showing the 2-year follow-up, and by 2 years, you still have 20% of patients alive compared to 2% in the control arm. So a 10-fold higher probability of being alive after 2 years. So, and in terms of safety, you know, these drugs have some class effect safety, some adverse events. Dysgeusia and muscle cramps are the ones that stand out the most, and fatigue to some extent. And sure enough, they're seen more. And yet, the patients were able to stay on therapy and continue seeing the benefit. Everything else was very similar between the 2 arms. There was no increased myelosuppression. There was no increased infectious complications. A little bit of more of these with the combination, a little bit of more of that with the low-dose RLC, but very similar side effects. So a very attractive treatment option for this patient population with a good safety profile that you know, gives us one more tool to add to these to the armamentarium.
Well, I think that's what we could say. We have another drug that we can now figure out how best to use in the management of our patient with AML.
And there are just ongoing combinations with hypomethylating agents, standard chemotherapy. So we'll see if that can be extended to these other groups.
Yeah.